Thank you so much for the opportunity to speak. And, you know, I had a bit of turkey for lunch. I'm hoping not too many of you guys did that because, you know, I've learned a lot of things at this conference. So far, it's a great meeting. One thing I did not know is that being right after lunch is really a telltale sign of where we really rank in terms of the speakers. So what I'm going to try to talk about in 20 to 30 minutes is targeted therapy and immunotherapy for melanoma. And, you know, 5 years ago, to give this talk in 20 minutes would have been very, very simple. And now it's actually virtually impossible to do that. I think based on, you know, really our increasing understanding of the biology of this disease, the increasing technology that we have to develop better therapies, there's just been a huge increase in the number of effective therapies that we have. There's a lot of things I'm going to talk about today, but I'm going to really use some of these new drugs as examples to show some of the larger principles of what we're thinking about when we're treating patients with this disease. And so what I have here is really, in 2010, what we had in our armamentarium of drugs when we were treating patients with melanoma. And so in 1975, dacarbazine, which is an IV alkylating chemotherapeutic agent, was approved. In 1994, interferon was approved for use in adjuvant therapy for patients with high-risk disease after resection. And then high-dose IL-2 was approved in 1998 as well. And importantly, if you look at the two drugs there approved for metastatic disease, the dacarbazine and high-dose IL-2, neither of these drugs had ever been shown to improve survival in our patients. And so the median survival for patients, you know, with these drugs was about 9 months. And I want you guys to just kind of keep that number in mind. In 2011, the anti-CTLA-4 antibody Ipilimumab was approved. So I think a lot of you guys have read about this. I think this is, you know, obviously been a very, very important advance. But this is an antibody that targets something called cytotoxic T lymphocyte antigen 4. And that CTLA-4 molecule is an important component of immune regulation. It's important in modulating the way the immune system can affect cancer. And Ipilimumab has served as a great model to teach us about how modulation of these immune checkpoints can affect cancer. And so one of the things that Ipilimumab has taught us is that, one, modulation of the immunological checkpoints can induce clinically relevant anti-tumor radiographic responses and also improve survival. But what's been interesting is the kinetics of response we've seen with this drug has been unlike the kinetics of response we've seen with other cytotoxic chemotherapies. So normally, if we're treating a patient with chemotherapy, you get a scan, you treat them, and in 6 to 8 weeks, you can get another scan. And if the treatment is working, you'll see disease stability or tumor shrinkage at that time point. But this is an example of a patient of Jed Wolchuk's, a colleague of mine, which this patient taught us an enormous amount. And what you see here is at baseline, you know, he had a very small amount of liver disease. You can't even really see it on the projected images there. But in 2006, he was treated with Ipilimumab, and the way we give this drug is an IV drug. You get it once every 3 weeks. We do it 4 times, and that's it. And so you can see after his treatment course, about 3 months after starting treatment, this is what the liver looks like. And if this was chemotherapy, we would clearly say that drug is not working. We've got to stop. But interestingly, look what happens just a couple months later without any further therapy. You can see that the significant amount of liver disease there has started to shrink. By week 36, it's even smaller. And again, this patient was treated for metastatic disease in 2006, and he's alive and well, cancer-free today. And so this kind of is an example of the power of immunotherapy with drugs like Ipilimumab. In terms of survival, Ipilimumab was actually the first drug to ever show that it helps people with metastatic disease live longer. This is data from, or this is the table from the publication by Stephen Hody at Dana-Farber, published in New England Journal, and it reports on the results of a 3-arm randomized phase 3 trial where patients were randomized to either a GP100 vaccine alone, which is that blue line, Ipilimumab alone, which is the red line, and then Ipilimumab combined with the GP100 vaccine in the middle. And so, you know, what you can see here is, one, there's an improvement in the median free survival from about 6.1 to about 10.5 months, okay? 2, one thing to notice on this curve is that what you see in the patients who got immunotherapy with anti-CTLA-4 antibody is that if patients have done well in terms of survival by about 2 years, recurrences and death was actually very uncommon, suggesting that, if you hit this tail of the curve, then we can in fact cure a percentage of patients treated with this drug. And so if you look at the 1-year and 2-year progression-free or overall survival rates, it's improved from 25% with GP100, which in our mind is essentially placebo, to 46% with Ipilimumab, and you see that same sort of pattern at year 2. One thing that I do want to point out on this curve also is the separation of the curves actually don't happen until about week 12 to 16. And this, again, I think is reflective of the kinetics that we can see. You can see it takes time, for at least in the case of Ipilimumab, for this drug to work. Steve Hody then presented a pooled analysis looking at 2 phase 3 trials of Ipilimumab, as well as 10 other trials, 8 of which were prospective phase 2 trials, and just looked at historical controls from other trials. And really what he showed here is that the median overall survival for these patients, and this very large number of patients now treated with Ipilimumab, was 11.4 months. 3-year overall survival rate is 22%. And it kind of strikes me that, just listening to some of the colorectal talks where we're talking about 5-year survivals on, single digits, to say that melanoma we're seeing a 20-25% 3-year survival, I think that is a major improvement from where we were before. So we've learned some other things. 2, the increasing understanding of immune regulation is providing additional promising targets for therapeutic purposes. And so there are a number of immunological checkpoints that have been identified that we can use for therapeutic purposes. And on the left here are some of the activating receptors. So these are the receptors that, if activated on the T cell, will lead to enhanced immunologic response. And so there are ongoing trials of drugs, antibodies targeting things like OX40, GITR, and CD137. And on the other half, you have inhibitory receptors. And so this is where CTLA-4 fits in. And if you can use an inhibitory antibody against CTLA-4, then you get T-cell activation. Another immunological checkpoint that's kind of been investigated a great deal is PD-1 and PD-L1. And one thing that I want to point out here is that the way that affecting these immunological checkpoints occurs, it's different. So if you look at CTLA-4, CTLA-4 is something that functions really at the immunologic periphery. It occurs at the level of antigen presentation, at the lymph node, at the area where the dendritic cell is trying to present antigen to the T cell. So this is a peripheral effect. And so inhibition of CTLA-4 with a drug like Ipilimumab leads to increased antigen presentation, increased T-cell activation. But on the other hand, when we're talking about PD-1 or PD-L1, this is actually occurring right in the tumor microenvironment. This is occurring at the level of the T-cell and the tumor cell. And so that inhibition of PD-1 or PD-L1 at this point is increasing the activity of the T-cell right at the level of the tumor. There are a number of PD-1 and PD-L1 antibodies in development, including drugs by BMS, Merck, companies like CureTech, Amplimmune, MedImmune as well. But of these drugs, the one that is furthest in development is Nivolumab. So this is the BMS anti-PD-1 antibody. And Susan Topalian presented and published this work in the New England Journal of Medicine in June of 2012. And so this is a spider plot looking at the patients with melanoma treated at the phase 1 trial of this agent. And so here, each line represents one patient. X-axis is time, y-axis is tumor change in target lesions from baseline. And so if the lines go down below the x-axis, the tumors are shrinking. And what you can see is the majority of patients actually get tumor shrinkage with therapy, such that 28% of patients here achieve a radiographic response. If you differentiate this with what we've seen from Ipilimumab, again, the majority of the responses here with PD-1 inhibition tends to be immediate. That's not true in all cases. If you look at this one patient here, this patient did have some increased growth, and in fact, this patient had the development of a new lesion there before having significant tumor regression. So just looking at the kinetics of response of CTLA-4 versus PD-1, we can see delayed responses with PD-1, although it's a little bit less common. This is a waterfall plot. Again, each bar represents a patient. And again, you can see that about half of the patients do achieve some level of radiographic response here. And we saw responses at all dose levels that we tested, as low as 0.1 milligrams per kilogram, with some patients achieving a complete response to therapy there. With this drug, on the phase 1 trial, the median overall survival was 16.8 months. And again, remember where we started, where our median survival was 9 months. This is a significant improvement compared to historical controls. 1-year overall survival rate for these patients was 62%, 2-year survival rate 43%. Another thing that we've learned is that the clinical outcomes and toxicity profiles differ by level of checkpoint blockade. And so if you look at the toxicities that we see, and this is just kind of for cross-trial comparisons, which obviously you're not supposed to do, but we're doing this anyway. This is data from the phase 3 trial of Ipilimumab by Hody, which I showed you previously, as well as data from the phase 1 Nivolumab trial. And what you'll see here is that in general, the toxicities associated with PD-1 therapy are less frequent. If you look at any immune-related adverse event, it's 61% for Ipilimumab and 41% for Nivolumab. If you look at the rate of severe toxicities, what we call grade 3 and 4 toxicities, it's 14% for Ipilimumab, 18% for PD-1. Rash is less common. Diarrhea and colitis, which is a relatively frequent toxicity with CTLA-4 inhibition, is uncommon with PD-1. The one thing that we do see with PD-1 therapy is pneumonitis, and that's something we're very careful to monitor. But if you look at efficacy, efficacy is also different. And so what I've listed here is kind of efficacy data from Ipilimumab, efficacy data that we have for some PD-L1 antibodies, and efficacy data from 2 different PD-1 antibodies, Nivolumab and the Merck drug Lambralizumab. And so what you can see here is that if you just look at CTLA-4 versus PD-1, the overall response rate is 11% for Ipilimumab versus 31 or 41% for PD-1 inhibition. This is data from survival from the respective trials, 10.1 months for Ipilimumab versus 16.8 months for PD-1. And if you look at the 1-year and 2-year overall survival rates, 1-year survival rate is as high as 81% on this trial of Lambralizumab, the Merck PD-1 antibody. So all checkpoint inhibitors are not the same in terms of toxicities as well as efficacy. Now, Jed Wolchuk at our institution has worked with Mario Schnoll at Yale to look at the efficacy of combining some of these checkpoint inhibitors. And so this is some data from the phase 1 trial combining CTLA-4 inhibition with Ipilimumab with PD-1 inhibition with Nivolumab. And this is the waterfall plot. And what you can see here is, again, the number of patients who are achieving radiographic responses is quite high. Overall response rate is 40%, but what you can see here is that the depth of responses, the patients achieving a near complete response, is extremely high, higher than what we see with single agent alone. And here, this is a slide presented by my colleague Mike Postow at the Melanoma Bridge meeting. This is the data from the phase 1 Nivolumab trial, and this is data in terms of the survival curves for the concurrent phase 1 trial. And you can see 1-year overall survival rate for combination therapy here is 82%. So we may be able to increase the benefit seen with CTLA-4 or PD-1 antibody therapy by combining treatments. Now, so there's a lot that we don't know, and I'm not going to have time to go through. It's kind of listed here, but just as to kind of go through these quickly. One is, what is the relative contribution of changes in specific T-cell subsets? Are we really, is this working by enhancing the efficacy of T effector cells? Are we affecting the Treg population? Another key question is, what are the biomarkers that we're going to be able to use to help predict which patients are going to benefit? And there are a number of biomarkers that have been shown to either predict benefit or have promise in doing so. And obviously, we're looking at some of these other checkpoint molecules as well to see if those are going to be better targets for therapy. And again, we're combining checkpoint blockade, not just together, but with chemotherapy, with targeted therapy, with radiotherapy, and so forth. Now, back to the timeline here. There was another key point in kind of the timeline for melanoma drug development in 2002. It's not shown here, but that was a publication by the Wellcome Trust Sanger Institute showing that BRAF mutations were a frequent event in melanoma. And from the time that was found, there was a rapid effort in terms of developing drugs to block that event. And in 2011, the first BRAF inhibitor, vemurafenib, was approved for treatment of BRAF mutant melanoma, followed by the approval of dabrafenib, another BRAF inhibitor, and then trametinib, which is a MEK inhibitor. And so this is data. This is a slide from Paul Chapman from my institution, reporting the RESIST responses achieved in the phase 3 trial, where patients were randomized to chemotherapy or vemurafenib. And so this is the waterfall plot for dacarbazine, and this is kind of what we expect. Most of the patients progress. Overall response rate is low. On the other hand, this is the waterfall plot for BRAF inhibition, and there's clearly a marked difference between those two waterfall plots. The overall response rate is nearly 50% for the BRAF inhibitor. So we can achieve significant response rates with drugs that block that pathway in patients whose tumors are driven by BRAF mutations. And that's not unique to vemurafenib. We also see the same thing with dabrafenib, which is the GSK RAF inhibitor. Waterfall plots look very, very similar. Response rates look very similar. Now, in addition to pushing or enhancing the response rates, we also improve overall survival, and we see that both with vemurafenib, where there's a hazard ratio of 0.37, so a 43% improvement in the likelihood of survival, and we see that with dabrafenib as well. Now, these drugs aren't perfect, obviously. Below here are the progression-free survival curves, and what you'll notice is that although most patients achieve radiographic responses with these drugs, the benefit is not indefinite. Most patients will ultimately recur, and the median time to recurrence is about 5 months. Okay, so we can get initial disease control in the majority of patients, but it's not completely durable. I think looking at data from the TCGA for melanoma, this shouldn't surprise us, because even if we just look at the BRAF mutant population shown here, and the mutations are coded by green, we can see that even the BRAF mutant melanomas are not a homogeneous subset. Now, although the rate of concurrent NRAS or KIT mutations in BRAF mutant melanoma is uncommon, about half of the patients will have a CDKN2A loss. A small proportion will have CDK4 mutations or amplifications. And so it's clear that just using BRAF mutations to select which patients are going to benefit from these therapies aren't enough. And so there's been a lot of work looking at various resistance mechanisms to figure out what is going on in the tumor cell to allow it to escape from control. And this is a really nice paper from Pirolito from Memorial, who kind of summarizes the different mechanisms that have been reported for resistance. I think the bottom line on this slide is that whether secondary resistance occurs due to parallel pathway activation, splice variants of BRAF, secondary mutations in NRAS, the end result is that you get continued signaling through the MAP kinase pathway, through MEK, and through ERK, despite continued effective BRAF inhibition, okay? And so this suggests that perhaps if instead of hitting this MAP kinase pathway, this growth pathway that's driven in melanoma at the level of BRAF, maybe if we hit lower at the level of MEK or perhaps even ERK, then maybe we can overcome that resistance. And in fact, this trial, which randomized patients with BRAF mutant melanoma to trametinib, which is the GSK MEK inhibitor versus chemotherapy, did in fact show that you can improve progression-free survival versus chemotherapy, and that's shown here. You can also improve survival as well with a hazard ratio of 0.54. But again, there's the development of secondary resistance in cases as well, so inhibition of MEK isn't going to be sufficient. There are a lot of trials being evaluated to kind of assess various hypotheses as to how can we overcome secondary resistance. And these are looking at different dosing schedules, use of CDK4 inhibitors, and so forth. But the trials that are furthest in development are trials looking at dual pathway inhibition at the level of both MEK and BRAF. And so this is a waterfall plot from the BRIM-7 trial, which is the phase 1 trial combining vemurafenib, the BRAF inhibitor, with cobimetinib, a MEK inhibitor. And again, in patients who did not receive a prior BRAF inhibitor, you can see that all patients had a response to therapy. The response to therapy in vemurafenib-resistant tumors, though, is less common. What you do see, though, is this impressive PFS survival curve for patients who have not received prior vemurafenib. And at this early time point, the median PFS had not been reached for this patient population. So it may be that this combination can improve survival. This is data from the trametinib and dabrafenib phase 2 trial, showing that combination therapy with a higher dose of a MEK inhibitor improves PFS versus dabrafenib alone. And so the phase 3 data is pending. It'll actually be presented for that dabrafenib-trametinib trial at ASCO. A lot of the progress that's been made has been based on the understanding that melanoma is not just one disease. And so I've spent a lot of time, at least on a molecular basis, talking about what do we do about BRAF mutant melanoma. There's a lot of work going on trying to define what is wild-type melanoma, what are the drivers there? And so there's work ongoing. But it's clear that inhibition of NRAS with MEK inhibition may be a rational strategy. And so data from the Novartis MEK inhibitors shown promising activity, and that's being pursued in a phase 3 trial. Our group and others have shown that KIT inhibition in KIT mutant melanoma can be effective as well. And so drugs like imatinib or nilotinib or sorafenib may be applicable for a small subset of patients. And we've also done a lot of work looking at the subset of melanomas harboring mutations in something called GNAQ and GNA11. And these are mutations that are commonly found in a type of melanoma called uveal melanoma or ocular melanoma. I think for the sake of time, I was going to use the ocular example just to kind of talk about how we think about developing trials. But we did show in this one trial that selumetinib, another MEK inhibitor, can be effective in GQ, G11 mutant melanoma. So where are we now? Well, if you look at our small molecules, this is kind of what we see in terms of survival. With the small molecules, we can get rapid effects, we can get major tumor shrinkage frequently, but secondary resistance is common and most patients will ultimately succumb. Whereas if we look at the immunotherapies, we see delayed responses and less common tumor responses, at least with CTLA-4 inhibition, but we get that tail of the curve effect, suggesting that we are able to cure a proportion of patients. And so hopefully, with further therapy, further study, we'll be able to shift the curve, cure more people. And these are just my concluding comments. One, a number of new molecular and immunological therapeutic targets have been identified and have led to the development of multiple effective treatments that are meaningfully improving outcomes of our patients. Further work is definitely necessary to identify biomarkers predictive of sensitivity as well as primary resistance, and we do have to figure out what's driving secondary resistance. Despite all of these advances, though, much more work is needed, and so I will leave it there, and happy to take any questions.